The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to today's webinar as put on by the NCBTMB and the Massage Therapy Foundation. This webinar is sponsored by Handspring Publishing, and it is part 5 in our series on research. This research webinar will feature massage therapy for pain management. I'm Dr. Portia Resnick, president of NCBTMB, and I am joined today by Doug Nelson, my counterpart, the president of the Massage Therapy Foundation. Welcome, Doug, and tell the listeners a little bit about yourself.
Hey, Portia. Nice to be with you today and to speak about this subject, which I hope everyone will find fascinating. So I am the current president of the Massage Therapy Foundation, and I've been in practice for 40-some years. But who's counting? And, I wear many different hats, an author, educator, but I have to say the hat with which I am most comfortable is being in the treatment room. It's what I love and have been doing, seeing many people every week for decades. And for me, it's where it all starts and ends, is there, because that's where I feel of greatest service and the thing I love the most. So it's fun to share this and be part of this thing and share this information about pain. So thank you.
Thank you. And yes, I'm hoping that our listeners today will learn a few things that they can also bring with them into their treatment room with their patients, their clients, because that's really who we're all here for. So let me talk a little bit about my organization, NCBTMB, which is a nonprofit organization, and we're here to define and advance the highest standards within the massage therapy and bodywork profession. Our signature series is our board certification in Therapeutic Massage and Bodywork credential. This is the highest voluntary credential that a massage therapist can achieve. In addition, we have specialty certificates. We grant approved providers the ability to share their continuing education, such as the Massage Therapy Foundation, which is one of our approved providers. And we also have our assigned school code program, which helps massage students fast track into the board certification route. If you'd like more information, you can visit us at our website or talk to one of our very awesome staff. And now for a little bit about the foundation from Doug.
And hey, Portia, it's our birthday. We're 30 this year, which is pretty amazing.
Wow!
So I'm not
Happy
going to sing or anything.
birthday!
I know I'm not going to sing or anything, but it's 30 years of really advancing the knowledge and practice of massage therapy. And it's really about 3 things. It's about supporting scientific research, and over the 30 years, it's about $1.5 million going towards scientific research in the field of massage therapy, and making sure that that is massage therapist driven, that therapists have an input into this. And that's really important because we want that research to reflect practice in the field. Education, it's great to put out that kinds of research, but we want to make sure that people can understand it and utilize it. And then also community service, which is the philanthropic aspect, bringing massage to people who really would never normally have access to it. And over the years, about $500,000 has gone toward that, and some really just tug at your heartstrings kinds of projects. So there are many different projects and research conferences and all that sort of stuff. You'll see that on the massagetherapyfoundation.org website. There's tons of resources for the profession.
And just by listening to our presentation today, you can earn 1 CEU because, as I said, the Massage Therapy Foundation is an approved provider, and they are graciously offering the opportunity to earn that 1 CE today for the webinar. And please stay tuned to learn how to get your 1 CE. We'll announce that at the end of the broadcast.
So let's
get started with get started with our topic. And our topic that Doug is going to present for us today is on chronic pain, something that we all have faced with our clients.
Amen. And what a multifaceted, what a complex problem, and truly at a national and also global level, Portia. If you look at like some of the statistics on here, this is from 2016, but essentially 20% of the population of the United States has chronic pain. 20%. So that is a lot. That's 100, potentially 100 million people who have chronic pain. And if you look at it annually, these are estimates, but somewhere north of $500 billion a year. Those are the costs. And that's inside the United States. There's something called this Global Burden of Pain survey. And with that, the estimates are about 1.5 billion people across the globe have chronic pain. And again, it's multifaceted when you think of it. For instance, here's one little thing. People who have chronic pain are also 4 times more likely to suffer from anxiety and depression. So, now you have these kind of 2 things colliding and each one feeding into the other, which makes it far more complex. A little while, Portia, I looked at the title of this research study and I was kind of curious because it was about chronic pain and tobacco use. Like, what? But it makes sense. If you're trying to quit smoking, if you're also in chronic pain, that is incredibly difficult compared to people who are not in pain. So then you look at what are the health costs of that. So, the ramifications just keep spreading in all directions. It's probably not surprising to you, Portia, that low back pain is the leading cause of kind of years lived with disability. So as the population ages, and that is true worldwide, people are living longer and they're having more musculoskeletal problems. And it's not just pain, but the incidence of musculoskeletal pain is increasing rapidly. And guess what? That's an arena, a domain that we as massage therapists can make a difference with.
Absolutely.
And of course, we can't really talk about this without at least addressing the opioid crisis. But as I've heard several people say, it's not just an opioid crisis that we're facing, it's really a pain crisis, of which the opioid crisis is a part of that. I think the awareness of this, Portia, really came in about 2008, 2009. But look at the trend. This is up through 2018, but man, those numbers just kept going up and up. On the chart on the left, this is overdose deaths involving any opioid, that's prescription and non-prescription. But then if you look at the right, also, this is just prescription opioids. This is why this is such a serious problem. I think it was last year, 2 years ago, something, I taught in West Virginia, and I just asked the whole group that I was speaking to, about, 50, 60 therapists, how many of you have like an immediate, person, in your family or contact that has been affected by the opioid crisis? I don't remember anybody not raising their hand. It was a jarring experience for me. So it's, the regional areas have more of a problem with this, but it is really devastating. One of the things I have to say is the Massage Therapy Foundation, in 2018, we actually funded a study about opioid use with children in pain. And this was done at Nationwide Children's Hospital and in Ohio. And they did some really cool research. And there are a couple of research perches on the foundation website that you should take a peek at. And there was another study that was funded in 2011 on massage therapy for opioid-dependent patients. So this is an area that the foundation has explored. And, it's also really interesting, I just find this fascinating because there are many negative implications for addiction to opioids. But, here's one of them that I find fascinating is, as we learn more, that people who are, taking opioids, we have our own endogenous opioid system, so that, it's that sense of well-being. You see a sunset, it's like, oh my goodness, you get flooded with this wonderful, these are endogenous opioids. But taking opioids externally, medication actually seems to kind of screw up that internal system, and that's part of the reason it makes it so difficult to get out of that cycle. It's very complicated, but if there are any ways that we can serve to help either prevent that from happening, much more difficult once it already has, but it's a very complex and very national health crisis. So when we look at pain, most of what you hear now is this understanding. It's moving away from the biomedical model, which really had three tenets. The cause of pain can be seen, the cause of pain could be identified, and therefore the cause of pain could be eliminated. It's a lovely idea. It doesn't work, but it's a lovely concept, But now everything is moving toward this, understanding of, biopsychosocial, biological, psychological, and sociological. There's some other, there are biochemical aspects to this and whatever, but we'll stick with these kind of three arenas. And they're all, important and equally so. In different, times and different eras, different ones get emphasized. The biological obviously is really important. Somebody I saw this morning had a back surgery that was nothing short of miraculous, So these biological things, an issue that is specific to, the spine, they are definitely real. But there are also incredibly important psychological influences through this whole thing that we are more and more understanding how important that is. And I think what gets less focus and less highlighted are the sociological things, which we'll talk about today. I think one of the things that we have to understand in the complexity of researching this is in research, many things are actually what we call unimodal. So if we do this intervention, what happens? So we pick this singular thing. But just looking at this screen, you see that pain is really influenced by so many different things that it's really hard to have a unimodal approach to a multimodal system. And in many ways, researchers try to account for this, but it's a daunting task, and it makes it all the more difficult to research interventions in pain. If anything we understand, you have to approach it from multiple viewpoints and multiple perspectives.
And when we look at the research, Doug, is there one of the three of those areas that is more prominent or less prominent in the research?
Yeah, I think certainly in years past, Portia, it was more about the biological, and then in recent times, I think there's been more of the psychology of pain and how important that plays into it. So I think you see more of that now. And I'm just starting to see more of the sociological stuff surface in the research. So, we kind of go in phases with these things. So, and that's the current understanding, and stay tuned because it will change, right? Such is the nature of this.
That's the best part about research.
Amen.
Somebody changes
Amen.
what's out there.
Yeah. So, I think the point I would like to make today, and obviously I have a bias because I am, a longtime massage therapist, but I think that our profession is truly uniquely positioned to address pain on multiple levels, including each of the three arenas that we just mentioned. And I hope when we go through the presentation today that, that will become obvious. And I think if for all the therapists listening to this, when you think about it, I think that will be an easy, conclusion to come to, just based on our own experience with clients who come to see us every day. And, one of the things about this is, in this study of pain, whatever, it's not about coming to an answer. It's about more deeply understanding the question. And I think the more deeply you understand something, the more likely you are to feel like you have some power, some control over the process. And I think that's one of the reasons to explore this.
And I think that's interesting too, because as massage therapists, we're not looking to read a research study that's going to tell us, oh, if we do this massage treatment, this is going to take care of pain. It's understanding the pain and bringing that evidence, that research into the room with us so we understand how to approach the problem.
I couldn't agree more, Portia. And I think some people initially have the idea that research is somehow prescriptive like that, you know, like for people with this, you do 4 of these and 3 of these. It's like almost never that. It really just deepens your own understanding, because it's your understanding that you bring into the treatment room, right? It's not, you come with this deeper breadth of understanding, and then from that understanding, you will formulate a response that makes sense, and a response that is based in that understanding of the current data. So, well said. You know, one of the things about this, and especially, you know, when you look back to the opioid thing, Portia, is that you can't just take something away. You can't tell healthcare providers, well, you just shouldn't be prescribing opioids. Well, that's a nice thing to say. I mean, that's the subtraction, but what's the addition? Like, in lieu of what? Now, what are we supposed to do? And so this joint commission, which came out in, I believe, 2018, 2017, you know, really said that hospitals, you have to look at non-pharmacologic pain responses to some options for patient care, of which massage therapy is one of those things. So it really was a driver in helping the healthcare system, and I know the VA through their whole health initiative. You know, they're really looking for what are ways that we can help people navigate through chronic pain, and in a non-pharmacological way. So there's great emphasis in this, and I think we as massage therapists have a role to play in this. You know, it's just wild when you think, you know, let's start with the definition. Word pain, like, where did that word come from? Actually, the Latin derivative of this is the word poena, which means to punish. Wow, think of the implications of that. You know, I mean, it goes back to the story of Job, right? Like, you know, all his friends, you know, Job's in all this pain, and his friends are saying, whoa, you must have done something really serious to deserve this, right? And Job's thinking, I can't think of anything. Like, well, it must have been something terrible. And, you know, I just heard an interview 2 days ago, Portia, with somebody who wrote a history of pandemics. And it's very interesting. They were talking about, I think it was, I forget which one, but it was middle 1800s. Really the perception then was that people were getting sick, and it was a moral crisis, you know, that somehow, you know, they were being punished for some moral, you know, failing. Oh my gosh, you know, and it was a pandemic. So, you know, it's just a devastating backdrop to this, with that, you know, earlier idea of pain as punishment. And we see things like, how many times have we heard clients say, what did I do to cause that? As though there were a singular cause, like the very last thing I did caused this pain. And if I just didn't do that, then I wouldn't have this anymore. It's just not that linear and not that simple. So I think it all, in a way, goes back to the name.
And it also goes back to that biopsychosocial model that you just were talking about, right? It's psychologically, it may be biological, but they have that psychological response, and the people around them have that sociological response. So it all comes right back to that.
So now you feel bad, and you feel bad for feeling bad. How bad is that?
Yeah.
Right? Like, ay.
Mm-hmm.
So, you know, the definition from the International Association for the Study of Pain is this: an unpleasant sensory and emotional experience associated with actual or potential damage or yeah, I know that sounds like it was written by an attorney, but it actually, inside of that is, you know, the current understanding, and I've seen many versions now where they're looking to rewrite this, and that's probably coming soon. But, you know, a couple of things I would point out: it's an unpleasant sensory and emotional experience. It doesn't say or emotional experience, it's and. So pain always has that, the unpleasantness part of it, that's the emotional thing. And when you look at, there's no place in the brain where, you know, pain is processed There are multiple regions, but many of those regions are also regions of the brain that deal with emotions. That's part of the process. So it's an and. And then it says associated with actual or potential damage. And you think, like shouldn't it, it's a kind of a yes or no. Not really, actually, because one just crazy example of this is somebody that I saw 2 or 3 years ago. And I saw her in the summer before Portia. She was in this terrible whiplash accident. And now, it's a year later, she's pretty much recovered, but she's in the car with her husband and she's in the passenger seat. He's driving. The 2 kids are in the back. They come to this intersection. They start pulling forward. She looks out her passenger side window and sees a car coming at them at a rate of speed that her brain does the calculation, mass times velocity times squared by the hypotenuse of the whatever. And she says, oh, well, you know what she says. And then the car like skids and fishtails and comes up so close to her window that she cannot see the grill of the car, but it never touches her car. And yet, here's the thing. She cascades into all sorts of pain, just like she had the year before. Her husband had to change his underwear because it scared the bejesus out of it. And the kids are like, wow, that was cool. She's the only one in the car who is in pain, but there was no impact. In the very definition associated with actual or potential tissue damage. So technically, and very much in a real sense, she's in pain after that. So the problem with pain in many ways is that there's no painometer in the brain that you can, glance in there and go, oh, it looks like we're up to it. There's nothing like that. So certainly in the past, it's about self-reporting, and it goes to that the person is in exactly as much pain as they say they are, which has been kind of a rule for decades now. But it's still problematic because it doesn't help us do this. And oftentimes we've used things like the verbal reporting scale, on a scale of 1 to 10. Well, that's great if you actually know what a 10 is. I've never had a kidney stone. Obviously, I've never been pregnant either. So I don't really know what a 10 is, because those things would probably register as a 10. So when you say on a scale of 1 to 10, as related to what, right? So, and I think in the treatment room, we've all had this where a client says, oh my gosh, it's an 8, and and I cleaned the garage yesterday, and I did this, and I did that, and they're like, if it's an 8, I doubt that you would do all those things. But how do you explain that to people? Well, here's the next slide is this Defense and Veterans Pain Rating Scale. And I love this because it incorporates kind of multiple things at once. So, for instance, if you look at a 6, the pain is really hard to ignore, right? And I avoid stuff that I usually do because of that pain. That makes sense to me, right? It's based on function. The little faces, that's the facial scale that they often use for kids and that sort of stuff, but again, it gives a functional meaning to the numbers that are on the page. And I can't stress enough, I really like this scale. I've given it to, we have this at our clinic on a laminated thing, and that's what we use, but I've given it to many physicians. In fact, when I had a physical, I probably shouldn't say this, but the nurse came in and, it was one of the questions on a scale of 1 to 10, like, how much pain are you in? And I just looked at her and said, I hate that question. It's kind of useless, right? And she looked at me kind of startled, and then she said, yeah, I hate asking people that question. I was like, well, let me give you something. And, so now at my doctor's office, they use this as well, and everybody's happier because of it, because there's some perspective. If you'd like a copy of this. Go ahead, Portia.
I was going to say, it's really easy to understand. I think we can all relate to this, which means that our clients, our patients can better relate to this as well.
Absolutely, and that therefore it has more meaning. So if you'd like a copy of this that's high resolution, go to the Massage Therapy Foundation website. Just type in the search bar, "When Actions Speak Louder." It's a blog post I wrote, but it has attached to it a high-res picture of this that you can photocopy, I think it's like 5x7 or something like that, and then laminate it. The next slide is the back side of that little thing. And, that also has, some really nice questions that deal with sleep, mood, stress, activity, that sort of thing. So just avail yourself to that. It's a really nice resource. In the next
and
slide,
since we are talking research, can I just ask, have these pain scales, has this pain scale been validated in research studies?
Yeah, so this was actually, again, put through from the Department of Defense and the VA, and they have been using this now extensively and have done lots of research on this and have had really good data that this is a pretty accurate way to explore this. So avail yourself of that. This one, I've seen this in research studies. Talk about simple, right? It's cut to the chase, pain, enjoyment of life, and then general activity. So it's taking everything down to 3 questions, but you could make a case for this, and I've seen it in multiple research studies. The next thing is when people in pain say, and how many times have we heard people say this, I want my life back, what if you could somehow, sit on the couch all day, like do nothing, but you were in no pain, I don't think anybody would want that, right? Like when they say they want their life back, that means the activities they do. So this is one scale that I know Robin, who couldn't be with us today, she had a kind of an emergency at her work to take care of, but I know she is using this, and PTs will do this at all. Here are these activities that are kind of functional activities of daily living. And then how confident are you in your ability to do these things? It's a really nice scale because measuring pain really comes down to measuring function. So I just saw somebody yesterday, and she had come in and initially with some really difficult cervical issues. And the cool thing is she had to undergo this test. And every time they put her in this position for the test, it cascades her into pain for days. How we know we're really making a difference is her neck was a little uncomfortable for a few hours after that test, but then she was right back to, being fine. So, it's getting someone out of pain, is one thing, but keeping them out of pain, keeping them being able to live their life, that's a more important metric. So function is always the way to look at that.
And we all love to share those success stories.
Yeah, you bet. You bet. You have to savor those because working with people in pain can be difficult, right? You have to savor those moments when yes, we're making some progress here. If we talk about chronic pain, we do have to at least address the acute pain, and that's important. Acute pain is really in a way like an alarm system, and it's very much so. When you have acute pain, it really is that pain equals damage. Like if you keep doing this, nothing good is going to come about that. So it's a warning system. And it really has 3 things, 3 lessons for us, which is on the next slide, which is that it sends a message, listen, buddy, you better stop before you really injure yourself. That's one thing. The second thing is, okay, don't do that again, right? And the third thing is, okay, I'm going to shut the system down for a little bit. I'm going to stop you from being active until you have time to fully rest and recover. They're all perfectly appropriate and very helpful in acute pain. The problem is, like so many other things, what is beneficial in the short term can be disastrous when applied in the long term. So all of these things, like for instance, if you look at this, someone who suffers from migraines, right? Tell me what you're learning, in terms of that. Not a lot. You can't apply the criteria of acute pain to the chronic thing. For instance, if you look at low back pain, we'll talk about this later, limiting activity to avoid discomfort for more chronic back pain is a really bad idea according to the current research. So you want people to be as active as possible. So the response to acute pain should be in response appropriately to pain that is acute, not applied to chronic. So in chronic pain, in general, it's pain that outlasts normal healing times, and here's where it gets really crazy, or after the noxious stimulus is no longer active. And that's, wow, that can be really difficult. Especially, it's hard to explain that to people because, you know, it's like, what are you saying? You know, like the cause is no, like, are you saying this is in my head? It's like, no, the pain is absolutely real, but the thing that started it in the first place may not be there. And, you know, it's crazy, but I think about, you know, the other day I was going into my office and, you know, I was carrying way too many things in my hands because I'm a guy and, you know, you can only make one trip, you know, you can't make two. And so I get in the office and I'm trying to punch in the alarm code, then I couldn't do it. So I went forward to set some stuff down, tripped the motion sensor. Now, oh my gosh, I'd never heard that. It is so loud. I think you could hear it in 3 counties. I can't remember my name, let alone the alarm code because of the sound. And you know, I don't need the alarm to tell me I'm an idiot. I know I screwed up, right? But now the alarm is the problem, right? There is no thief. I get it, but it just keeps going. And in many ways, that's what chronicity and pain happens, that the pain just keeps going when the cause no longer is there. And there are so many examples of this. Or that the impairment is greater than you would expect with the physical findings, which can be iffy as well. So chronic primary pain is a way of defining that. The chronic primary pain means that the pain itself is the problem. You can have chronic secondary pain, right, which is secondary to some other source of this, but chronic primary pain is when pain itself is the problem, generally longer than 3 months. And again, here we go again, significant emotional distress and functional disability. So chronic primary pain. It's just, you know, somebody posed this and I just love this idea that chronic pain is not acute pain on Groundhog Day syndrome. They are very different things. And we need to see them and kind of make that dividing line between understanding them and therefore responding to them. This image is something that actually Whitney Lowe brought it up to me, and I just really like what Whitney posed here. You know, there are this idea that and I've had people say to me, and I bet therapists out there have had the same thing, where people say, it can't be muscular because it hurts too much. Like, what does that mean, right? I don't think so. But it, you know, muscular means it's not that serious. And so anything that hurts that much must be really serious. Well, this is really faulty because you can have a cancer that is going to kill you and no symptoms, no pain whatsoever. You know, you get a paper cut on your tongue and you just want to like die. I mean, you know, like, and yet the tissue injury is so small. So the idea that pain is in relationship to tissue damage is just not true. So on the biological front, you know, this is, you know, looking at presenting this to everyone, you know, it was tempting to go through like all these different studies and, you know, massage is shown helpful for this condition and that condition and this, but there are tons of those things out there and those are accessible. And again, through the Massage Therapy Foundation website, you can take a look at all the different research studies that we have done. And actually I did that. I looked back through all the ones that we posted on our website back decades. It's really interesting, Portia, how we've funded things that are biological, we've funded things that are psychological, and also we've funded things in the sociological arena. You know, for decades, we've been doing that. That's pretty cool. If we just take the simple
awesome.
Yeah, you know what? I didn't realize that until I thought, oh, I should pick, you know, something as an example. And then it was like, well, how many am I going to pick, right? And then it's like, oh my gosh, and they're in all these different arenas. I had never even realized that until just, you know, a few days ago preparing for this, which is like, wow, it's like we actually knew what we were doing, even decades ago. So there are many basic science studies, but one I'll just highlight, which is in this funding cycle that we have initiated, which is a study on massage for atrophy done by the University of Kentucky. From the days of Swedish massage and on, for centuries, we've been talking about how massage can be used to recover, and for people who are can't be active, keeping them at least functional and healthy. But actually, when these researchers looked at the literature, there wasn't a lot to support that. This is actually a really, really cool study looking at massage and having people be inactive and see if they can keep that tissue really healthy. It's fascinating. So we need tons of studies like this in many different ways, even like frequency, like how often should people get sessions, frequency and duration. There just are so few studies about that. Like how often and for how long, what is optimal? There's so much work that needs to be done. And we at the foundation are just coming out with a brand new research agenda that kind of lays out a roadmap for a call for research for the future. So stay tuned, that's coming.
I'm looking forward to that, because I tell you, when you tell people you can get massage 2 or 3 times a week if you're a research participant, you really don't have trouble trying to sign people up for those.
I don't know why. That's amazing. That's right. So, and again, often clients say, when should I come back? It's like, well, I mean, I can tell you my clinical experience, but wouldn't it be nice? And we don't need, 2 studies. We need 20 studies exploring these kinds of relationships. So there's so much work to be done. In the arena of pain, though, just in that, years ago, there was this systematic review and meta-analysis that was done as a collaboration between 3 entities, the Samueli Institute, the AMTA, and the Massage Therapy Foundation. It was an enormous contribution to the field. And if you have this handout, you click on these links and it will take you to the Massage Therapy Found website, which will then take you to the full texts of each of these, and it's a wealth of information. At first, we were hoping to come up with just one, but it turned out there was so much information that turned into 3 different things. 1 for pain in general, 2 for pain and anxiety and cancer, and then a 3rd one for surgical pain. So, and the impact, the number of downloads, the number of reach, the amount of reach that these studies had in the field of pain management in general was astounding. This was an enormous contribution to the field. So when we talk about pain, we really need to at least address this idea of sensitization. And what that means is, again, we have this idea of that and kind of the emotional realm that, when under stress, we get super sensitive, where you just kind of are hyper aroused and maybe over respond to a whole class of stimuli. And that can happen in just a straight out biological way, peripherally. This is something where if you have let's say for instance, you have some difficulty in your forearm, and it may just be initially one particular muscle, whatever, let's say the extensor carpi radialis brevis. And then pretty soon it's like there's this spread that everything in the forearm is sensitive, but again, it started with one place and now it super sensitizes the neighborhood, as it were. So that's peripheral sensitization. And then central sensitization is when, and we'll talk about this in just a second more, but over-sensitizing the whole central nervous system, which has an effect, of course, on everything downstream. So the reason I have a roach on the picture, I'm sure people are like, what the, it's really funny. A few years ago, or pathetic, a few years ago, I was presenting and there were about 80 people in the room in this hotel on pain, and I was trying to come up with an example of sensitization. So I thought I had this brilliant idea, and I've since learned if you ever think your own idea is brilliant, you should just not do it. So I made up this story that the hotel had a problem with roaches and that people should get their personal effects off the floor. And so there was total chaos for like 10 minutes. And then I kept talking for about another 15. And then I said to the group, is it just me or is anybody else actually seeing a roach? Almost half the group raised their hand. And then I fessed up and told them that I made it all up as an example of sensitization. Yeah, that didn't go over well with the group, and I can never go back to that hotel again. But the larger thing is, how can you see roaches that aren't there? And again, if you're predisposed to this, if you're super sensitized, when you see anything that looks like a little movement, your brain says, oh, that's a roach, right? So the same thing, like any stimulus, you go to, the person says, that's a little too much pressure. And you're thinking, oh my gosh, I was just putting the lotion on. Like, wow, that's this principle called allodynia, where even touch is perceived as pain. So again, that's peripheral sensitization. And we have to find a way to turn the volume switch down. So here's one example of this, and this was posed by a man named Patrick Wall. And it's this idea that, so you have the nociceptors in the peripheral tissue. And if you, for instance, have an injury to your leg, those nociceptors are sending information back up to the central nervous system. Well, if you have somebody put you under anesthesia, the question remains, what happens to those peripheral, that input? And the answer is nothing changes. They're still firing like crazy. So what Wall said is, why don't we shut down the periphery and then actually deal with the central? And would that increase somebody's ability to heal? And the answer to that seems to be overwhelmingly yes. In fact, my wife had a surgery on her leg a couple of years ago, and the nurse anesthetist came in and described how he was going to do injections around the site where they were going to do the surgery, and then they were going to, of course, I was sitting there and I had to break in. Well, do you know where you got that information? And in 1980, and yeah, that's, my wife threw me out of the room. But I had a really cool conversation with the nurse anesthetist afterwards, because he didn't know where that idea came from, right? It's just that somebody told him, you should do this. But, all these research ideas then somehow, and it takes a long time to become integrated into practice. Think about that from the massage therapy perspective. Are there ways that we can kind of downregulate the periphery and also downregulate the central mechanism? I think the answer to that is yes, because there are mechanisms in massage therapy that can target each of those specifically. So I think we can use that principle as well.
And it's amazing how we can take research that is really medical research and apply that to our practice clinically. So thank you for sharing that one. I'm going to try that.
Yeah, and again, it's about that translational moment, right? Like you read something and then it's like, well, wait a minute, I bet there's a way that I can apply that to my practice, which is never what the researcher, intended. But it's almost every technology, everything like that, was that the end usage probably wasn't really what the original conception was. That's what creativity is all about, And, central sensitization is fascinating because, again, when the central nervous system gets lit up, then it affects everything below. So the poster child for this, Portia, is clearly fibromyalgia, which is why, you can't get fibro in your right knee, right? It is spread across the body because it is coming from the central nervous system. So all the approaches that tend to work best with that tend to be things that are targeted toward kind of down-regulating the central nervous system rather than being, hyper-local, hyper-focal in the periphery. However, again, what are ways that can upregulate the central nervous system? Well, all of these peripheral inputs, for instance, if you have central sensitization, and you also, as in the picture here, you have an issue in the vastus lateralis, that's sending information up to the brain that there's a problem in zone 38, And then if you think of all the different areas of the body where there could be potential sensitization that is at a smaller level, but it's still upstreaming information to the central nervous system. When we actually are working with people and can deal with all of those small peripheral insults, now we are turning the volume switch down centrally. And that's one of the reasons that people have such really good reactions to the work that we do. It's through that mechanism. So just because it's central sensitization doesn't mean that peripheral input is not important. In fact, it can be a large factor in propagating central sensitization. So this is this idea of spatial summation. And I'm kind of broadly applying that term. It can be used in a very hyper-focused local way, but I'm actually looking at it too in a much larger thing. Like if you're trying to fill a wheelbarrow, are you filling it with multiple small shovels of dirt, or are you filling it with one big, input? For most people, the way to central sensitization is often the spatial summation. It's the sum total of multiple small inputs. And there's some really good research being done at the National Institute for Health on this, where it is, we keep thinking, what's that one big driver that's doing this? And it turns out it's not the one big driver. It's the sum total of multiple small drivers, which in one way, Portia, is frustrating because you're not going to hit the home run. On the other hand, if you can, because there are many of these smaller inputs, one by one, if you can take these out, each of these is another piece to the puzzle that you can address. So it actually ends up giving us more options to be able to deal with it. So it's a really important thing. And so kind of the term for almost that fibro presentation, although this is broader than that, is chronic widespread pain, which is, again, pain that is both on both sides of the body, above and below the body, both peripheral and also axial. It's just, in this research study, I thought it was really interesting. If you have pain in more than one region, you are 4 times more likely to transition to chronic widespread pain, which is definitely where you don't want to be. So the more locations you have it, the more input there is, and here's that spatial summation again, that's more likely to push you into chronic widespread pain. We're all familiar with the term of homeostasis, but I think most of us less familiar with this term allostasis or allostatic load, which is honestly, it's like the camel that broke, the straw that broke the camel's back, where it's this, like spatial summation, it's the sum total of all of these things rather than looking what was the one thing that did this. It's the sum total of all of these different inputs. And this is applied in many different ways biologically. It's what metabolic syndrome in many ways is about. No one thing is the problem. It's the sum total of multiple things that are slightly out of balance. But while that's true in that realm, biochemically, we should also think about that somatically as well. When we, again, if we can help people through these smaller inputs, it just turns, again, the volume switch down at the central nervous system, and good things happen as a result of that. So one way that many of us use in helping in terms of the central nervous system stuff is breath, right? This was really fascinating. I just happened to run into this study a couple of weeks ago, actually. And what they did was fascinating. So they had, people use breathing techniques to see if it, helped them deal with pain. And the answer is it's very helpful. Here's the thing. They also gave people naloxone, which blocks opioid uptake. So again, this endogenous opioid system, you have people do breathing techniques, give them naloxone, it still works. That's wild, right? So you'd think it's the relaxation thing that somehow it's going through that same endogenous opioid. it's happening in a system outside that. So here we go again, Portia. We end up with not another answer, but deeper questions of, well, if not that system, by what system is this working? So stay tuned. It's an endless and unfolding mystery, but what we know is breathing techniques really do work and are really effective in addressing pain and their effect in the central nervous system, but not by the mechanism that we might have thought.
And there's something, again, that we can bring right back into our sessions with our clients, because we're always telling them to breathe and to keep that at the forefront. And when you start talking about that, more of my area of interest is autonomic nervous system, and we know that we can get that parasympathetic effect with some of that deep breathing. So there's so much to even continue to look at with that.
Yeah, and there's so much new research about that in just the last like 2 or 3 years. So, and some of that is referenced in that study. So this is, again, when you go to a study, it's always like, well, where did they get that idea from? And then look at those references and, oh my gosh, you're down a rabbit hole for 1.5 years, but it's a really cool rabbit hole. So, all right, on the psychological front, let's talk about ways that massage can really have a very positive effect with that as well. And some of this is obvious, and maybe a couple of things will be a little non-obvious. But let's talk first about pain and invalidation, which is the next slide. So invalidation, when I was writing a book on pain, and interviewing people, this is one of the things that I heard from people who struggle with pain is, sometimes it was well-meaning, but both from providers and family, people felt invalidated. I think of one woman, Portia, who was just this lovely, person with a smile that would light up the room, but she was in tremendous pain. And because she was so pleasant, nobody would believe that she was in pain, right? Because people think, when I'm in pain, I'm a real bear. So you can't be in pain because you're actually nice. And so she said, I said to her, kind of remarked on this, and she said, it has not helped me to try to be pleasant. It's actually worked against me because people do not believe that I actually hurt. It's interesting. She said, I wish I had a cast on my arm, because then people would see it and then, believe that I had some issue. How sad is that? So, and there's that, if you experience what you experience, but maybe there's a diagnostic image and that is taken and it doesn't show anything, well, now what, right? Like, there are people who've seen 2 or 3 or 4, healthcare providers, they don't see anything. And pretty soon they start to think, well, maybe it's like, it's like, wait a minute, I know what I feel. My leg hurts, they're just because you can't see it does not mean that I do not have it. It's a really important thing. And, there was a study that was done a while ago that I found really fascinating. Part of the reason for the study was, what is the great proliferation of MRI? And part of it is what the lead researcher here said. There's if the doctor orders an MRI, he was listening to me and acknowledged that there's something wrong, so it's really a validation thing. So, wow. Understandable, but this is an expensive thing to do, to say the least, okay? We, on the other hand, in massage therapy, are so lucky, in the next slide, because we can actually use touch as a way to validate people's experience through replication of symptoms. How many times, for all of you who are listening out there, how many times have people come to you and you find something in the tissue and they say, oh my gosh, that is what I've been feeling. From their perspective, think of how powerful that is, how validating that is, that yes, I knew it, right? This is what I feel. That's a very powerful experience that we are able to provide for people. And, just this morning, when I was treating somebody, this person said, oh my goodness, does that feel tight to you? That's really code for wow, that's really sensitive. Can you feel what I feel, right? It's not the, do you feel tightness in the muscle? What they're really saying, they're looking for validation, right? They're looking for, this is sensitive. Is what you feel, does that make sense to you? Because this is what I experience. And I think we need to see it in that way. So we are lucky that we can do that. And it isn't just what you feel, it's what you think it means. So somebody I saw the other day is a very high level musician who has arm pain. Now you can, somebody else who has arm pain, their arm hurts, right? But with her, it is, this could be a threat to my livelihood. Like I have worked my whole life to perform as a musician, and this pain can be a threat to my personal identity and my livelihood. So it isn't just what you feel, it's what you think it means. And I want to explore that in a couple of different ways. First, I think it's important that in terms of what we feel, when we're exploring, for instance, where you're treating somebody and we find things, it's often quite, sensitive, right? And people are like, whoa, wow, that really, and how strange is it that it's sensitive, quote, quote, painful, but it feels like, oh my gosh, is that a good thing, right? That hurt's good phenomena. How is it, here's another mystery, that the brain knows hurt from harm, that the brain says, this is a really good thing, even though it's painful, So, but a lot of it's driven by the context in which it's experienced. So that's why we have really lovely environments. We take the time with people, we develop a relationship with them. This is this therapeutic alliance, you're building trust with them so that they can have this experience and experience it in the light of that very positive context. It really matters. So I think we as massage therapists are really good at creating a context for them to experience that. And it also matters into what you attribute it to. So if you click once more, so now you have, like, let's say somebody comes in with, and they've gotten a diagnosis from a medical person of degenerative changes in the lumbar spine. The reality is there aren't a lot of things you can do about that. However, imagine that you get massage for 3 or 4 sessions, and now your pain has gone down by 70%. Well, now that changes things because, in fact, it's probably unlikely that the x-ray is any different and your arthritis has not decreased by 70%, but now in fact you feel better, therefore you attribute the pain to more soft tissue things, which are things that you can actually do something about. That is really empowering. Next. And, I'm old enough to remember that years ago, we used to have this thing of, Portia, I'm sure you'd cringe at this, but, bed rest for back pain. Well, that is hardly the recommendation anymore. We know that we want people to get, to do as much movement as possible, that's actually more protective. And it's a nice thing to say that, like you should move more, but if movement is painful, it's hard to do it. If we as massage therapists can make it more comfortable for people to move, then they're going to move more. And if they move more, pain will be less. So, which is called descending inhibition. So in a way, that's a really cool thing that we as massage therapists can do, is make movement comfortable and therefore possible. And in the next slide, you see this. This was a lovely study about massage therapy and osteoarthritis of the knee. I mean, it's osteoarthritis. Massage isn't going to change what's happening in the arthritic changes in the knee. However, in this study, overwhelmingly, what people said is they felt empowered because they were able to do more. Now we're back to that functional stuff. They were able to live their life, to perform more activities of daily living, and that is empowering to them. That's a gift that we can give people, hope and empowerment through more comfortable movement. And this leads to this idea of self-efficacy, where again, people feel like they have some agency, some control in the process. And if we can do that for people, what a gift through the work of massage therapy to help people feel like, you know, there's something I can do about this, instead of this is something about which I am powerless to affect. And we are actually funding a really interesting study on left ventricular devices. I'll have you go to the Massage Therapy Foundation website and look this up, but it's also about self-efficacy in this very serious medical procedure. It's a fascinating study. I'm excited to see that get going after the, it's on a little bit of a COVID hiatus right now, but good things are coming. So as massage
I am looking forward to that.
Yeah, it's a really interesting study, and I don't want to get lost in this, but you definitely need to check this out on the website. So questions for LMTs to ask, you know, and it's really about, we want to understand how our clients make sense of their pain. Like, for instance, it's that person who says, well, of course my back hurts because, you know, I have a diagnosis of arthritis. It's important to know that perspective from them, you know, because then we know kind of the backdrop with which they're seeing this. And same thing, you know, what do they think about treatment? What are their belief systems about this? Really important. And I think another important question is, do you know anybody else who's had this? Because again, on the whiplash side, if you know one other person who's been in a whiplash and their experience was horrendous, you think, well, that's what's in front of me, except you don't know that n equals 1, right? So I think by giving people a broader perspective, yes, it might be true for that person, but here's what the data says across the board. There's no guarantee that you're going to fall into that. You might easily fall into these things. It just opens up the world to people. So, but we wouldn't know to do that unless we ask them that question. So the questions we ask obviously are really, really important. We're going to finish up here. I know we just have a couple minutes left, but on the sociological front, and here too, I mean, how many times have we seen that relationship aspect of massage therapy, you know, be super important to people? And here's a couple ways that we'll explore to do that. Number one, on the next slide, please. Yeah, so you know, we're looking at challenging the person's sense of autonomy, one's need to belong. And I want to just end with something called perceived injustice, which is really, really interesting. So loss of autonomy, you know, that's a really interesting thing, because many people really struggle with that sense of loss of control. This is a little bit, again, about what we felt before about that self-efficacy and giving some agency in the process. So the more people feel like they have some power in addressing their pain, the better their experience is going to be, big time. A variable in this is on the next slide, which is this unpredictability. And this is something that pain and stress really share together, is that predictability and controllability are really determinants of one's experience of pain and of stress. So in the research world, you know, uncontrollable pain is perceived as more intense, more harmful, and more unpleasant than controllable ones. And there's some really clever stuff in the stress research as well. Stress that is somewhat predictable, like, you know, okay, I have to mention rats. I mean, we can't talk about science without bringing a lab rat into this at some point. So if you take, you know, lab rats in a cage and you just do this mild shock that happens at exact, you know, time frames, you know, the rats just figure out, okay, you know what, every minute and a half this is going to happen, whatever, and then they just live that. But when you start varying it and it starts, you know, in a random and unpredictable way, that is really difficult. And that's why, honestly, Portia, the current environment that we're in with, you know, COVID and everything is so unpredictable, that just heightens the stress level and pain level for everybody. So, and the last thing is really interesting here. Losing control over pain is even worse than if you never had control over it in the first place. It's like, I had it, but I lost it. That's even harder to deal with. And, pain can be incredibly isolating. I wrote a piece for Massage Magazine on touch deprivation and pain in the elderly. And the longer, the people are in pain, in chronic pain, oftentimes it becomes more and more isolating because there aren't people that you can share that with, or you've been invalidated, and you just keep closing the circle. And this is problematic in terms of the outcomes for people who struggle with chronic pain. So any way to broaden that circle and increase that, and that's again why the massage therapy room, being in relationship, somebody who is totally focused on you and can hear your story and have empathy and connection, human to human, is a very powerful relationship thing. And again, we've all experienced that as so positive for people who are in pain. Something you wouldn't think about, again, if you hurt and you decide, I need to take time away from work. But for many people, work is also a big part of our social construct and our social web. So this is a really interesting study looking at when people are taken away from work, it also creates a sense of isolation, and that actually can make the problem worse. So how do we navigate giving the people the care that they need and the rest that they need without taking away the social structure that they also need? It's multi-layered and complicated. Lastly, this idea of perceived injustice is really interesting. So Portia's sitting at the light and she's just waiting for the stupid red light to change. I mean, how long is this going to go on? And then all of a sudden I am driving in the car behind her. I'm distracted. Boom, I slam into Portia. Biomechanically, just the mechanics of the accident, Portia is the one who's going to be injured more. And so Portia is the one who's going to go to have multiple medical appointments. She's the one dealing with insurance companies. She's dealing with all the negative effects of the accident, but I am actually the one who caused it. The experience of pain is worse when you have perceived injustice. And wow, it's really, it's another piece of this that you have to take into account. And if we use that PTSD model on the next slide, you see there's a really interesting relationship with like PTSD and whiplash, especially, again, Portia didn't know this was coming. And so all of a sudden, in 0.3 of a second, her life has changed. And the incidence rate then of PTSD in people who suffer a whiplash, especially if they didn't know it was coming, is really interesting. And it's part of that whole thing, and is linked to you having much poorer outcomes over time. So if we know that from the beginning and we think about those things and address it in that way, using strategies that at least acknowledge and address that, that has to be a beneficial thing. And it's not just, here's what happened to the tissue. It's also a much larger construct with this as well. So, and I think the more we know that, the more we can address it. So in summary, again, our work really addresses all of these things and, always has, but I think if we come to it with that understanding, we'll do it much more thoughtfully, much more intentionally, and hopefully that way much more effectively. So awesome. So again, go to the Massage Therapy Foundation for all these different resources. We are your foundation. We're funded by donations from therapists like you, and our goal is to give back to the profession and to really support the profession for generations to come. That's what foundations do. And thank you for the privilege of doing that.
Well, and thank you. You've not only brought us some information that we can take into the treatment room when we're working with our clients or with our patients, you also brought us some great information that can give our viewers the chance to earn 1 CE.
And that's here. So if you just go to this website, just click on that, and then you'll see this webinar. This will be posted. You can take the quiz, and you'll also see some of, this is number 5, but you'll also see 1 through 4 there as well, and do avail yourself to those. There's some great information in there.
There is, and we have had so much fun doing these webinars. I hope we're going to continue the series. I know we are. Some deep thanks and appreciation to Handspring for their generous sponsorship of this webinar. We could not do this without having some help. And not only are they helping us out with this webinar today, but they're also going to give some special discounts for the next few months. It's almost Christmas time, so maybe we want to put some of these textbooks on our holiday list.
Good idea. So the future webinar, we're looking at maybe in February. I think it would be a really cool thing to explore massage therapy and the immune system and what the research has to say about that. So that'll be fun. So we're looking at February 3rd at 1 p.m. Central Time.
Yes, we're part 6. So thank you from myself, Dr. Portia Resnick, and the NCBTMB. Again, feel free to come visit us on our website or chat with some of our staff to learn more about board certification.
And for the foundation, massagetherapyfoundation.org, and the research journal, the International Journal for Therapeutic Massage and Bodywork, IJTMB.org. Sign up and you'll get notified of any new articles that come out, or just connect with us. Thank you, everyone. Thank you, Portia. Thanks for taking the time to do this.
Thank you, Doug, for your great insight.